So hi. So from Beijing Field One Hospital, and I think Professor LINGHU is going to perform a live demonstration on the poem procedure. Professor LINGHU.
Yeah, and so first of all, Professor Wang introduce our team. We are very glad to see you online in Hong Kong. Next case performed by Professor Enqiang and assistant Dr. Tan Li.
Hello.
Here is
Hello.
endoscopy center.
Hello.
Gastroenterological department of POA General Hospital. We congratulate this time the workshop. We got great successful and I hope to see you next time in Hong Kong. Now the next the case report, Dr. Dan.
Okay. Case report. This is a 57 years old man with the chief complaint of the intermittent dispute for 40 years with 1 year exacerbation. This patient has previous treatment of endoscopic Botox injection 3 months ago. Such as the high level to confirm the diagnosis of the eclampsia. The morphological classification is LINGHU and the classification is Chicago subtype 3. The procedure to be performed upon the demonstrator is the Professor LINGHU.
Now, first, this is the position we use is the spine position, the right shoulder rest. And now you can under the endoscopy, the endoscopy we use Olympus CLV 290. And now endoscopy reach the G junction. It's very tight. And from here, we go back about 8 to 10 centimeters. Minus 40, and here is the about 30. The classification of the multiple classification of this patient, that is the type 3B.
Type 3B.
And type 2B.
I see. Links classification. I know.
The endoscopic mucosa information classification, the EMIA, that is the B2C. We keep up find the some mucosal viruses veins, and so there may be slight inflammation. For this case, it's the history about 40 years. So some mucosal infection is very common. First of all, we use the injection, use the needle injection about yeah. Yes. 7 millimeters.
So Professor LINGHU. Yes. So you are using what device for the poem?
This is knife.
Oh, really?
Triangle. Yes.
Oh, TT. Okay. And the posterior approach, posterior.
Yeah.
Ah, okay. So you like to do a incision, a lateral side incision?
Yes. That is the bottom T incision.
I see. Oh, T. So what is the advantage of the T?
Yes.
What is the advantage?
The advantage is that is the longer is 1 centimeter longer,
I see.
and there is easy inside.
Ah,
Clear?
so easier to get in.
Yes.
So Professor LINGHU, what kind of electrosurgical setting are you using?
That is the early.
Irby.
Irby. Spray coagulation or other types of coagulation?
That is the first coagulation.
So I think just now we have asked Professor LINGHU about his classification. In fact, that is very helpful. I remember that in one of our workshop case a few years ago, we cannot get into the submucosa because a very severe fibrosis, and that is a classification that Professor LINGHU pioneered to know how much submucosal fibrosis. So some case it's difficult to get into submucosal tunnel.
先回来注射你。好，不用你这个直接打不起来。
好，对。
So Professor LINGHU, you always do posterior approach? Posterior?
Posterior?
So what is the advantage of posterior compared to anterior?
Yes.
就是从后壁进去的都是，
Incision submucosa from the size of the tunnel.
Yes.
Now this is a vector. We use convolution. Yeah.
I think generally nowadays most endoscopists like to perform POEM by posterior because the alignment is better, and the knife and the channel is also in a more ergonomic way. So and also easier to develop the tunnel, and I think randomized trials show no difference in the clinical efficacy between anterior against posterior. And a systematic review also demonstrate no difference in terms of the clinical outcome and also the exit reflux rate. So we can choose between anterior or posterior.
你去给他对话。
对，他就是这个。我要给我有。对。快到了是吧？
他回来。
This is a new type TT knife. You can injection.
I see. So a TT knife with a water jet function.
Yeah, inject button.
Yeah, so it's enhancing the procedure, and of course, Professor LINGHU is doing very fast in the tunnel, but I think the injection also help at the same time.
Yes.
Very effective. Cardio.
Very nice injection. We can see a very good tunnel, submucosal tunnel.
Yeah.
So you must have many thousands of patients receive the poem before. So about the the clinical outcome. So what's your experience? I mean, in terms of relief of the dysphagia after the poem, is it a very highly successful?
Yes, my. Yeah.
他说什么？
So how about acid reflux after the poem?
A large vessel, so how is coagulation?
What's your question just now?
Yes.
What's your question just now?
So what about the acid reflux? The rate of gastric acid reflux?
Oh, gastric reflux. Nearly maybe 20%. 30%.
Yes.
Yes, 30.
Yeah, I think we are similar. So we are around 20 something reflux rate after the poem.
Yes.
对的，再查一下渐进性气切开怎么说？渐进性。
So I think as if you're learning to do poem, one of the key points is how to avoid going spiral inside the submucosal tunnel. So Professor LINGHU, do you have any tricks to teach those who want to learn doing poem how to maintain a straight tunnel to avoid going spiral in the submucosal tunnel?
I have a book that.
Recommended this book is Professor LINGHU is the main editor. In this book reveals about the standard steps of the poem procedure and the other endoscope. technique about stir and include stir and ESTD.
I see. Thank you. Thank you.
LINGHU is a famous specialist on therapeutic endoscopy. He got many awards from China and America, the same as you. Thanks, Philip.
Philip is a very famous doctor. I'm a doctor.
Now nearly the cardio, so maybe opening this here, in this place is heavy at here.
There's a Chinese name also performed this very nice.
Thank you, introduce.
Now here's the injection, which is near the cardiac.
不要涂的太内行了。最黏连。
That's
here.
Yes.
So you should be careful and maybe 去年怎么说？Avoid incur the mucosa.
Yes.
It looks very tight here. Very close. The mucosa is very close.
注射行吗？这样可以哈，可以。针不要取的太多了，那个长虫不要取太多，取成对了。
是的。
The left side is mucosa side.
Yes.
The reflect disease in the ecclesia. So this just located in the cardiac. A lot of cases is the issue is here. That is.
Yes. Yes. So sometimes in this very tight area, even injection may not be very effective because the LES is so tight.
Wow, this is look very tight. Very tight
tight.
junction. Yeah, very tight.
So any tricks? How do we overcome this difficulty?
Slightly we'll try, and we have another model that is POM SSMD. That's just for this the issue, serious the issue.
Oh, really tight. I think sometimes in very, very, very tight LES, one of the way to overcome this is probably to pre-cut a bit of the muscle so that it widens slightly so that you can still squeeze it through, hopefully to get into the cardia for the better view.
Here.
Okay.
Here.
Okay.
Yes, now there's a bit of plane coming up.
郑教授的中文也是有 English very well.
Yes, yes, you get through the tightest part. You can see the.
Oh, okay, okay.
We can see the.
Very nice.
The cardia region now.
Nearly success.
Yeah, I think this is a very important point of demonstration, and Professor LINGHU did a really, really nice demonstration how we manage the tight G junction.
And now pass the tighter part of the EG junction.
Yes. And I think we start to see some spindle veins.
Personally, I think as GG says, this is the key step of the whole procedure. The first of all, we are careful. We should differentiate the mucosal layer and and the muscular layer. And then I say, personally, I think the intermittent submucosal injection is very important.
Yes.
As you know, the biggest benefits of the POEM is rebuild a barrier to prevent the infection. Here, the mucosal formation is often occur. So we should be very, very careful here.
So, Professor LINGHU, how would you confirm that the tunnel has been adequate? Would you perform a double scope, or you just use the current endoscope to be sure?
Perform the tunnel. I think that is enough.
Yes.
Yeah, I think a lot of time, if you have good experience, just anatomical landmark is good enough.
Yeah.
So you will start the myotomy.
Yeah.
Okay, I understand.
In our center, the progressive myotomy is preferred by Professor LINGHU.
So do you do a full thickness myotomy or a selective myotomy?
Muscle, how to circle muscle.
The first is a circular myotomy, and then it's about 5 centimeter distance to the GEG. We performed the 4 thickness myotomy. This we call progressive myotomy.
Progressive myotomy, I see. So do you find any difference in terms of the outcome with progressive myotomy as compared to selective or complete full thickness myotomy?
Yeah, we create this method to balance the clinical success and post-reflex events.
I see.
from our experience, the progressive anatomy is better than the circular or the force thickness anatomy.
So equal if efficacy, but maybe less reflux in your experience.
Yeah.
I see.
Just information by the Professor Chai, according to our experience, the rate of the growth course of the poem is about 25 to 30%.
25 to 30%. I see. So are they symptomatic or just endoscopic appearance?
So, Professor LINGHU, it's a really nice demonstration of the poem procedure. I think we learn a lot from this, and we understand that you are progressing very well with the myotomy. Unfortunately, we have a really, really limited time today. So, thank you so much for your live demonstration. We have to move on to our next demonstration. So, thank you so much, Professor LINGHU. Thank you, and the team. Thank you so much, Beijing.
Thank you.
301
Thank
Hospital.
you.
Thank you so much. Thank you.
Thank you.
Thank you. And thank you. Very nice.